Good morning and welcome to the Department of Obstetrics and Gynecology Research Day. As you all know, this is a very special day in the life cycle of our department where we get to present the research that we do to our own community as well as the broader SNPH community that decides to join us, and then anybody else that we can snatch and sort of get into our poster group. Now, in that context, I will say that it is my absolute special delight and pleasure to introduce a very special surgeon scientist today, especially because in that context, she is somebody who I think sympathizes very deeply with all of both the challenges and the opportunities that departments like ours have in building the research pipelines necessary to transform clinical care. It is our very own, Dean Neeta Ahuja. She is an absolutely remarkable person. I especially love that amongst other things that she has done in her life, she has a degree in mathematics, in addition to biology, which she did at the University of Maryland. And then she proceeded to do her medical education at Duke, and then proceeded to do clinical training at Hopkins, Oxford, and then joined faculty at Hopkins for the first part of her career. It's in that context that she made some initial, the very first in a long series of seminal contributions to the biology of cancer as an epigeneticist, having discovered the CIMP profiles in tumors relating to how tumor suppressors are silenced in the context of tumors. She paired that with amazing clinical focus on sarcomas, which all of us in OBGYN also care very much about, and then also with a leadership track that included an MBA because she wasn't busy enough. And so in all of that context, she then moved to Yale, where she became the chair of the Department of Surgery as well as the chief surgeon. And then we were just so delighted to welcome her to UW in the context of the last year. And what a time to become dean, right? So I will say we all live in some incredibly interesting times right now, but I think it's important to remember, and I take this from her, that every time of challenge is at the same time a time of incredible opportunity. And so we have our DNA of our Wisconsin idea, and I'm just really looking forward to seeing what kind of metallation Dr. Dean Ahuja will impart on our medical school and our system. Please welcome Dean Ahuja.
Thank you so much. Well, thank you for that incredibly generous introduction. It is really my pleasure to be here today with you for Research Days. I love Research Day because, of course, you get to talk to hear from incredible speakers, and you have a great guest today. Hear from your faculty, see the students' posters. So I think I got a few minutes late. I know that Dr. Benek was getting a little stressed, but I started talking to one of the students about one of the posters out there. But I think perhaps the best things about Research Day is the chance to pause, come together as a department, hear about the incredible work our colleagues are doing, and maybe for the faculty, the students, the residents, the next inspiration strikes. I don't think inspiration strikes while we're sitting on PubMed. Inspiration strikes at odd times. Sometimes it has been while I've been doing a case and then scrubbed out while my GYN oncologist came in to help me during a long case, because that's when ideas for clinicians strike, right? We talked about how clinicians, and especially procedural physicians, live a unique, challenging life as we have to traverse two parts. And I respect my medical colleagues, I respect my PhDs. I think in this field, especially for surgeons, we can't stop our surgical practice and just come in once, a few weeks of the year, because we need to keep our skills intact. And I'm feeling that right now because I haven't operated for a year and I want to get back into the operating room. And then you have to go and research is expanding exponentially. And how do we start to think about connecting the two and recognizing the tension? The answer is not we don't do research. because that's the wrong answer. I looked at some of the posters, and of course, there was a lot of oncologic posters out there, a field that I've spent much of my life. But there was also questions about things that perhaps only you are best poised to answer. There was a paper on C-section scars and how it causes ectopic pregnancy, and things around preeclampsia and how you can use the EPIC record. So those are questions you all have seen, you wondered, and you're taking the time. And I think that's the power of academic medicine. Now, as you just heard, I have been here now, this is year 2. Last Friday was year 1, and I have loved every part. Perhaps the only part I haven't loved is the -30, when it did hit -30. And that was the one day where I sort of said, oh my God, I did not realize it could get this cold. Because people said, you're from Connecticut, you're used to cold. And I realized, but this is such a special place. And perhaps for people who have been here a long time, you may not appreciate how unique it is that there's a culture of sort of civility, determination, hard work. Perhaps we say that's the Wisconsin idea. Perhaps it's the people who make the Wisconsin idea, but it's a self-perpetuating cycle that continues. And I'm always struck because outsiders recognize this, even if they're here for a couple of days. Academic medicine isn't often in a lot of turmoil. And I think when you're in the middle, yes, everything looks busy, but recognizing that this is a unique place. And that's what struck me. You know, I'm not from the Midwest. I recognize that. But I saw the spirit, even when I came in and met hundreds of people when I interviewed. And every day I have respected that I'm in a unique place. And despite when I came in, perhaps, you know, may you live in the best or worst of times, like I. And again, in that space, you have to thank yourself that you're in such a unique place where there's so much that's great. Yes, there's a lot of uncertainty. I'm not going to deny that, right? I am a realistic, I'm a pragmatist, but I also want to make sure that there's hope, that we are the hope for many, many people. So some things, you know, I've gotten to know this department. Last Friday I was at Meritor and really appreciated the amount of hard work that this team does in helping, you know, do something that's beautiful, bringing life. And you do it sometimes in beautiful aspects. And then there was the cramped workroom. And what struck me as a dean was that even in that cramped workroom, you made space for the medical students, for the residents to teach, to educate. That's what makes academic medicine so special. It's the commitment to the tripartite mission. It's what keeps us here, that you're always thinking, even when things may be just like, well, this room is really tiny as I'm looking at this. And I'm like, and then they told me, well, sometimes we sit on the floor. And of course, as a dean, you were like, oh my God. But I did not see anger. I saw that there was a commitment to helping women. And as we think about what academic medicine needs, there's an emerging understanding around perhaps the unanswered questions. And I'm not going to talk about, yes, there's lots of questions to be answered in oncology, but especially for women, whether it's in pregnancy or as women go through their sort of life cycle, as we think about menopausal changes, questions about benign tumors such as fibroids. And Dora Brzezinska is our Vice Chancellor of Research. And recently she did a paper that she brought in, and she's an engineer. She defined the GPS on the phone. And she sort of talked about what are the problems that are unanswered. Well, I'll tell you, the things she commented on were a lot in your field. And bringing how engineering solutions, I saw a couple posters with engineering, may be able to answer that. So Devesh Ranjan is our new Dean of Engineering. He started a month after I did from Georgia Tech, where Emory and Georgia Tech have really worked together to answer the questions. So there was a national symposium, and we're talking about that. How do we think about the unanswered question? The other point I'm going to tell you is that before I came here, I met with Carolyn Mazur. Carolyn has ran the Women's Center at Yale for decades, and she is amazing. She's really been committed around how to promote the career of women researchers, but also answer the problems that perhaps women face. And she was on the Biden task force, and I asked her, what are the big lessons you learned? And she said it was around women's care as she thought about it, cardiac care, pregnancy, issues of long-term complications. So again, I think you sit poised in an area to answer some of the big questions. Of course, there's many, many challenges as we think about how do we get the funding, how do we think about promoting and supporting our students, and learners and residents to be inspired when academic medicine or clinical medicine seems to be always in a maelstrom. And that's the importance of this today, of leaders in your department, and you have many leaders, I've gotten to know them, and inspiring. Inspiration is perhaps the best gift you can give. The other piece is perhaps what are the structural things we can all do as leaders. So in October of last year, I came in and assessed and got to know many of the departments, maybe learned some of the acronyms. We have a lot of them. And as we sort of started to understand all of the pieces, we had our first retreat. As a combined, and this is not like we don't have retreats, but it was the first combined retreat of all of the departments of the School of Medicine. So not only the clinical, but the basic science department with our partners in UW Health and university leaders. The Chancellor Mnookin also came in. And what was struck us was we didn't do this before. And perhaps our greatest strength is that we're co-located in a university where we can just go across and talk to people. That is more unique than you may realize. Even a distance of a few miles can seem like chasms for clinicians. And of course, our health system leaders understood that there was more than the 18 clinical department. That was a nice introduction. But the end point of that was that we have to connect together in what's known as the virtuous academic cycle. I've shown that in many, many presentations, but I'm going to talk about what that means. Academic medicine, of course, does clinical medicine that our other peers do, but academic medicine must do some other things that perhaps others don't have either the funds or the resources or the structure to do so. And what are those things? Well, of course, we deliver clinical care, but so do our partners sometimes in the community. The idea in clinical care is we're also innovating. We're thinking about the next treatment, next approach that someone hasn't thought about. That's manifested in the CHAP trial you're going to hear about today. So you're asking the questions and you have the power of collaboration to bring that. You're, of course, training the next generation. That's visible. Who are the residents and students in the room? Raise your hands. All right, there you go. Lots of them. Training that next generation because we need them, right? We need you. There's a huge workforce shortages, so all of you will have great jobs. And then the last part, of course, is doing research, right? Research to help humanity. We're in a school of medicine, and I know sometimes people say, well, should we do basic foundational research? I said, of course you should, but it's in the function, the purpose of self-serving human health, disease prevention, treatments. And as you look, Ken Goldstein is a political consultant who is from Wisconsin, so he's a proud Badger, and he does this for the nation. And he's been looking at the idea of what does research mean for people, and what does higher ed mean. And there's a lot of uncertainty in the belief of higher ed may help sort of improve livelihoods, economic stimulus. But when you ask people in the state of Wisconsin, he does a survey around the entire state of Wisconsin, and this is important. He'll say, is university important? People are starting to sort of wonder hugely about that. If you ask a research university is important, they're more favorable. If you ask what kind of research is important, it's the type you do, research that helps them. So there's a lot of interest in patients, whether they be in rural Wisconsin or our donors in understanding, and they understand because that research helps them. So my ask is do the research, but also learn to have your story so we can share those great ideas with all of you. And of course, there's uncertainty. I'm not going to gloss over that there's huge uncertainty in research funding, but this eventually we have to have hope in humanity that we will get across this and get to another side. Yes, the middle may be very choppy, and this is where our roles come in. So today, take the time, pause as much as you can. I know that you can't all pause because, of course, babies are being born and people have to staff the ORs, and we get all of that. For those of you who are here, take a moment, reflect, listen, think about what you may want to do, figure out your North Star. And for some of you, it may be a pivot from what you're doing to say, yeah, I want to do this because this is amazing. And with that, really, congratulations to all of you. I'm really excited that you're doing this. We're going to be doing our strategic planning. We're going to be doing a lot more of this with all of you to think about how do we perpetuate science? What are the ways we can make your glide path easier? And with that, thank you all for letting me, your dean, letting me come in and join your department and on Wisconsin. Who do I turn it? Okay.
Thank you. Okay, thank you so much, Dr. Ahuja. That was wonderful, and all those words are just like to the heart. So I hope everyone heard it. And to move on, it's my deep honor to invite Dr. Tita to our research day. He's a very important man in MFM, and to me, and inspiring for the research he's done, as well as what I could do, myself, and to teach and everything else, and include people in our MFM world and beyond. But Dr. Tita is a professor of OBGYN at the Mary Hersick Endowed Chair of Global Health and director of the Mary Hersick Institute of Global Health. He is the Hersick School of Medicine Senior Associate Dean for Global and Women's Health at the University of Alabama at Birmingham, UAB. Dr. Tita served as the director of the university-wide Center for Women's Reproductive Health from 2016 to February of this year, and his background is in maternal fetal medicine, perinatal epidemiology, and global health. He's dedicated to improving maternal and infant health outcomes and equity. He leads collaborative, multi- and single-site obstetric clinical trials and observational studies that influence practice and policy globally. He co-leads the Cameroon Health Initiative, a multidisciplinary collaborative by UAB and Cameroon partners to improve health. And he's also served as consultant for the World Health Organization, or WHO, NIH, including serving as the NICHD National Advisory Council, and then CDC, as well as the American Board of OBGYN. He's co-authored over 400 publications, was elected into the National Academies of Medicine and to the Association of American Physicians. He's made a huge impact in the care we provide for women with hypertension and beyond, and it's my true pleasure to welcome you to the podium.
Good morning, everyone. It's a really great pleasure to be here, and thank you so much for this invitation. Also want to go ahead and thank Dr. Hoppe, Dr. Stanek, and the other faculty members who took me out to dinner last night. I had a great time, and that was a bonus, just driving up here and looking at the lake. It's like amazing. It's the first time, I've been around the country speaking. It's the first time I'm coming into a campus and the lake is right there, and there are signs up saying for sale. Can you imagine that? All right. So when I got invited, there is a talk that I gave around just some of the challenges, around doing trials, doing studies. And in these times, I decided not to give that talk because I think it's self-evident. I also believe that, and that's to really what Dr. Dean Anu has said, really resonated with me, because we have these peaks of challenges, but we always get out on the other side. And, not to bring back memories, the pandemic was a really great example of that, and, see where we are headed. So I decided to just focus and talk about the CHAP trial. This has been an ongoing collaboration. We've been working with this with Dr. Hoppe and many others around the country who came around the table to make this happen. It's the power of collaboration. For the past 10 years, it's been going on now overall with NIH for at least 15 years. So I'm going to provide a quick update on this trial without focusing as much on the results, because it's getting 3 to 4 years since this was published, but speaking a little bit to the back story, and then also providing updates around where we are headed, because it's amazing to see how you start a project and you get going, but then the landscape changes, even definitions of things changing, and you have to, pivot and navigate those. So let me say congratulations to everyone who has a poster out there. And beyond what we did with CHAP, my hope is that if there are questions, it's really, again, how do we perpetuate the scientific process and research endeavors? All right, so no major conflicts of interest to declare. So this is the 2017 ACC AHA guideline that redefined chronic hypertension and brought that threshold for the diagnosis to 130/80 as opposed to 140/90. Now, going back all the way to about 2010, 2011, when we started talking about this concept, it was 140/90. And as you know, this question around mild chronic hypertension and how to treat it had been something that had been debated for 30 to 40 years. There was a NHLBI working group in hypertension, working group in pregnancy as early as 1990. And this was a question. How do you treat mild chronic hypertension? Should you treat it? So just a quick story. We came as a fellow, we were invited to sort of the department's research meeting held weekly around our Center for Women's Health. And the chair at the time walked in and said, okay, let's stop everything we are doing. Let's just sit down and throw darts at the wall and see what sticks. And so come up with all kinds of concepts and think about things, and let's debate those things and see what is viable. And frankly, that's how this whole concept around CHAP came up. And we thought, well, there is something to do about this bread and butter question and issue that we manage every day in clinic and in the wards. So that's how it came out. But what has happened almost 35, 40 years later is that through a collaborative effort, the CHAP trial was implemented. It changed practice almost immediately. That was, to me, one of the most amazing things. It takes sometimes a lot of time for evidence to be translated into practice. But the same day that CHAP was released, the Society for Maternal Fetal Medicine came up with new recommendations. ECOG, that same week, came up with new guidelines, and that was because of prior conversations and overall orchestration. The Society for Clinical Trials in the US identified CHAP as the #1 trial for that year. And then there's also a society, they call the Clinical Research Forum, that's affiliated with the Clinical and Translational Sciences system that's funded by NIH, also identified and selected CHAP as the #1 trial in the country, if not in the world. I'm very proud, but what I'm most thankful about is that it took a huge collaboration and people coming around the table and saying, we are going to do this, we are going to face challenges, and that's how somewhere about 6-7 years of actual implementation, we came to where we arrived. All right, so this is mild chronic hypertension. And that's how, I think we continue to define it in spite of the 130/80. And we use data from the Maternal Fetal Medicine Units Network, NICHD, to estimate at the time that about 70% at least of patients that we see with chronic hypertension had mild chronic hypertension. Prevalence of 3%, this continues to rise for obvious reasons shown here. And this is just briefly to say chronic hypertension in pregnancy is bad, right? You can see preeclampsia, 25%, and that's the mediator of most of the adverse outcomes. But you can also see preterm birth, 38%. I think this audience knows this very well. And then the next slide, again, is just why the significance, why do we do this? Chronic hypertension is even bad, right? Some of these rare things you can see as many as 16 times higher in those with chronic hypertension compared to those without chronic hypertension. And I just came off service last week, and it's the concentration of these kinds of abnormalities that we have on the world. So that's why we set out to do this. This is the ECOG practice guideline from 2019. I think that's what we all still use, right? Even though the CHAP results came out in late 2022. But this document was again put out in reaffirmed in 2024. But what does this document say? That if you have severe hypertension, absolutely treat it for the same reasons you would treat patients who are not pregnant. And with labetalol and nifedipine as first-line therapies. It's also, as you know, in earlier versions of many of these guidelines, aldomer or methyl dopa also was a first-line therapy, and then over time that got demoted. But then what about those with mild chronic hypertension? Withhold therapy, the risks and benefits of discontinuing medication are unclear, so it's reasonable to discontinue or continue. And that's the 2019 guideline, which is, again, an evolution from very early on when the general tilt and guidance, without absolutely saying so, was to encourage to withhold or stop treatment and restart if the blood pressures went back up into a severe range. All right, so even while this was being investigated, the position around treating or not treating was softening. All right, and why did we arrive at this? This was actually based primarily on the fact that when some studies had been done, there were no differences seen overall in pregnancy outcomes between those treated and those who were not treated. But these studies came with a lot of limitations, including having patients with chronic hypertension and patients with gestational hypertension or preeclampsia in the same population. But what really drove it was this concern about safety, increased risk of SGA with treatment, seen over several studies, 2 of them from early on shown here. Beta blockers associated with increased risk in SGA, but also any antihypertensive, as you treated and the blood pressure reduced, there seemed to be a trend to reducing or increasing SGA, as well as, in fact, low birth weight. And so that, I think, tempered recommendations to treat, and people opted to withhold therapy and see what happened. So we were faced with a situation where outside of pregnancy, the dictum was absolutely treat is the best thing that can happen despite the challenges of treatment. But then when it came to pregnancy, don't treat, and then maybe don't treat. And so because of this uncertainty and conflicting recommendations, I think people agreed that a trial such as CHAP had to be done. And again, I really want to emphasize it took a huge collective effort and collaboration for this to happen. A little bit of a backstory, I tell my mentees that, come on, let me open up my NIH application portal and see what is in there and the number of rejections, right, that I get. You have to keep swinging. You have to keep swinging. And then the interesting thing is, that's at least has been my experience, and the experience I've seen with those around me, is that once you start hitting, right? You're more likely, to get more. So you put those efforts up front and you get the dividends later. So we took this to the Maternal Fetal Medicine Units Network, been the PI of that network at UAB since 2010. 2010. And we took it there and it was rejected. It was rejected. But then a lot of other issues go into how these projects are selected into an NIH-funded network like that. So we still talked to the same group of people and said, okay, let's see whether we can set up a network outside of the MFMU network and still collaborate to get this question answered. At the time, I had at UAB, Dr. Susan Opperell, who is a cardiologist and eminent cardiovascular leader, one of the leaders over the years, over maybe 20 plus years, writing the guidelines for hypertension, the AHA-ACC guidelines. So I sent her an email and said, it looks like there is this problem in pregnancy and hypertension that we need to address. I tell you, within an hour, she responded. Again, I've just completed my thought. Within an hour, she responded and said, that's the problem I've been trying to work on. All right, so through that, we reached out to NHLBI, and frankly, the same day we reached out to NHLBI, they responded and said, we will be willing to look into a question like this, okay? And so that's how, CHAP all came about. So an open label trial, about 70 plus US centers. You can see the states shown in red, coast to coast. You can see many of the black dots were sites that were active by the time we were closing down the trials. Those white, some of them had enrolled participants, and some of them found it very difficult, and we shut them down, or they shut themselves down. But yeah, it took a huge effort. And NIH was very much at the table throughout. And again, want to thank Dr. Hoppe here, who has been a partner through this. In fact, we ran into recruitment difficulties because we started with we're somewhere about 14 site centers with a total of about 20 hospitals when we started this, and then quickly realized we had to expand and approached upwards of 70. And this is the question, should we treat to a goal less than 140/90 for mild or non-severe chronic hypertension? And will that treatment lead to improved outcomes? I had done some work with a resident looking at old MFMU chronic hypertension cohort. And this resident ended up having an oral presentation where we did analysis and looked at very different blood pressures and what the outcomes were. Severe, moderate, mild, and then a normal. And there was a clear dose response pattern in terms of blood pressure and pregnancy outcomes. So we use that to continue to make the hypothesis that if you treated early on to a lower dose, you could improve outcomes. All right. So who was included in the study? Those then with mild chronic hypertension. It could be newly diagnosed in pregnancy or pre-existing. We chose to go with single pregnancies, but we could also have included multiples. Singletons just, well, it's easier to worry about one baby than multiple and what you do with them. In more of our trials now, we actually try to include twins as well. And then less than 23 weeks. When we started, it was less than 18 weeks, but because of all the recruitment challenges and the fact that many patients with chronic hypertension came late as well, we had to open up. Now, we considered opening up to maybe 28 weeks, but worried about mixing chronic hypertension and preeclampsia. And so we decided to say, okay, we'll cut it off, pick 23 weeks and cut it off there. Was that the best cutoff? Where we said this will minimize that mixing, of those two hypertensive conditions. So I included those with severe chronic hypertension. Backstory again, we realized that many of us can sit here and we get our blood pressure and we're severe. And you may have two severe blood pressures over a period of time, and should you necessarily be excluded? And so we left it up to the clinicians, right? And also really looked at blood pressures. If somebody was in the ER or soon after pregnancy, they had severe ranges, there had to be some deliberative process to adjudicate whether it's really real or not, make a difference in who could get in. Chronic kidney disease, for obvious reasons, we didn't exclude diabetes, but some severe instances of diabetes. That's then fetal death and those with allergies to the medications. The active arm, labetalol or nifedipine, first-line therapies because of, according to the guidelines. But we also allowed, if a patient insisted that they were going to be, wanted to stay on their own medications after they were randomized to the treatment arm, we allowed them to stay on because the goal was not about the particular medication, it was about the policy of treating or not. And then the standard arm, obviously, if you were randomized to that, no treatment, or if you were already on treatment, stop the treatment, and then we monitored, and if the blood pressures moved back up to the severe range, then treatment was started. This is a primary composite outcome, preeclampsia with severe features, indicated preterm birth, less than 35 weeks, abruption, perinatal death, and these were centrally adjudicated to just make sure we got this right, because sometimes abruption may not necessarily be abruption. Then preeclampsia with severe features, this is how we defined it. The only comment I would make here is that we use distracting Is it? Yeah, let's figure that out. Now, if you're listening to us, there is from someone, if you could mute yourself, please. Is that good? That may be good. Get you back if it's not. All right. So after that break, so the most important thing here is just hypertension wasn't sufficient. It had to be hypertension and something else. And there is this whole ongoing debate. It's just severe hypertension, with severe features. I don't believe so. I think we look carefully at the drug definition. That's not the case. We can manage those patients as patients with preeclampsia features. All right, we also looked at SG as an outcome, and the sample size of 2404 was the final sample size, but backstory, the original sample size was 4,700. 4,700, we thought we had so many sites, let's get the sample size as large as possible. We were very conservative in terms of estimates we introduced into it, and then when we had recruitment challenges, quickly work with the DSMB, look at more realistic estimates based on what we knew, the literature, and through a blinded process that I wasn't part of and all the investigators were not part of, it was determined that with a sample size of 2404, we would have sufficient power, 85% power to detect a 25 to 33% relative reduction, assuming a baseline incidence of 30% and crossover of 10%. And crossover, that I really get your sample size way up. We also collected a bunch of specimens at enrollment at mid-pregnancy and then also at the time of delivery. So the results are well known. I'm not going to dwell on this. This was, again, published in the New England Journal. You can see, oh, actually 4 years now, May 2022. Who's been counting? And we enrolled screened about 30,000. So we actually screened 12 to get 1 into the trial. When we going in, we thought we were going to screen 4 to get 1 into the trial, okay? And 24 of 8 at 61 of those 70 plus sites actually enrolling at least 1 participant, and 97% outcome ascertainment all the way through to 6 weeks. On the right there, you can see among those excluded, 66% were excluded because even though they had chronic hypertension coming into pregnancy, we were just never able to demonstrate an elevation of medication. So if they had chronic hypertension, they either came off their medication by themselves or had that diagnosis and came in without medication. And if you were not on medication, we had to demonstrate an elevation to get you into the trial. And about 40% overall did not. And then the rest, gestational age, came in at a gestational age beyond 18 weeks at very early, short period, or most beyond 23 weeks. One of the reviewers, or some of the reviewers said this was one of the most balanced trials that they had seen in terms of how the two groups were comparable. But you can see that those on non-medication, about 56% were on medication. It's a minority, and you can see about 50% were Black. And then you can also see that obesity, about 75% plus in this population. 16% had diabetes. And then you can also see aspirin use at baseline was only 44% in this high-risk group. Some of this may be tied to the fact that guidelines would say give aspirin after 12 weeks. And so when we followed up and also documented aspirin use, at the time of delivery, that number went up to about 80%. Okay. All right. At randomization, most patients took the 2 first-line medications or were already on those, labetalol and nifedipine. But you see, there were a few on nifedipine who said, I want to stay on my nifedipine, and then very few on methyl-dopa and some of the other medications. The goal of this slide is just to show the last 2 columns. If you look at the very bottom of the last 2 columns, you will see that in the active group, only 11% of those were not on medication, right? So about 90% were on medication. You want that, that's compliance. And then in the standard group or comparison group, 75.6% were not on medication. So about 25% were on medication, and 15% of that 25, absolute, were patients who met criteria to be treated. So again, that shows a certain level of, not just a certain, a high level of compliance with the intervention, which was great because we kept on, I'm sure Dr. Hoppe heard this so many times, emphasizing to the group that you either, this trial will fail or stand on whether we were compliant with the interventions, and people came through. You can see that though there were modest differences between the comparison or control group in blue and the active group in red, modest differences, but you can see there were clear differences post-randomization. So there was a shift in blood pressure between those 2 groups, and these were blood pressures done at serial clinic visits, systolic and diastolic. And here is the primary outcome result. Everyone knows it's a very modest result, about just under a 20% reduction in that primary outcome, still with 30% occurring in the active group. So there's still a lot of work to do. There's still room to go, but that was a difference between the 2 groups with a number needed to treat of about 15. So for 15 patients treated, you prevent one of these adverse outcomes. And this, to me, is probably the more valid finding when you show a survival analysis taking into consideration the time to the event. And so you can see that the hazard ratio there is 0.79. So still consistent with the other comparison. But what to me is remarkable here is that the effect tended to occur later on, right? You can see within the first 16 weeks, both groups were not different. Those lines are like, so the effect of antihypertensive therapy occurred much later after randomization, like 12, 16 weeks later. And I think that may have something to do with development and diagnosis of preeclampsia. And the color code is different here. The active group obviously is in blue, not in red as previously, and the red is the control group. But to me, I would like to figure out what is going on early on here and what is going on late there when you see those 2 curves separate. All right, the components here generally lower in the active group. This is components of the primary outcome, but you can see significantly different for preeclampsia with severe features and indicated preterm, but the other smaller numbers not statistically different. Subgroup analysis, you can see overall saying the findings were consistent across so many different subgroups, right? Even when it crosses, the line, you could still see that for the most part, it's towards benefit. Where people may raise questions will have to do with this new diagnosis of hypertension, where that dot is at the null line, and also at the very bottom, those with more severe obesity. But analysis looking at heterogeneity did not show any significant difference. No difference in SGA between the groups, no difference, whether defined as less than 10 or defined as less than the 5th percentile. And then when you look at more severe outcomes, some of the cardiovascular things that occur, they are rare, obviously, in this young group, but lower, even though not significantly so in the active group. So a trend that we want to see. And then other components, any preeclampsia lower with treatment, severe hypertension, I think this was already well known that severe hypertension would be lower, similar. And then also looking at neonatal outcomes, a similar, rare, the very severe outcomes rare, but you can also see lower, albeit not significant in the treated group. So in summary, treating mild chronic hypertension reduced adverse pregnancy outcomes with a number needed to treat of 1 to 15 and did not impair fetal growth. I already mentioned about the ECOG practice advisory that came up the same week, so in May of 2022. And whereas that ECOG bulletin remains active from 2019, they clearly add this advisory to it to say you have to modify how you treat mild chronic hypertension. And then the SMFM recommendation as well along the same lines. All right, so since then, what has happened? I'm gonna be very brief here. A sub-analysis looked at labetalol versus nifedipine and did not show any difference between those two groups in terms of impact on outcomes. We saw that patients were more likely to switch from nifedipine to labetalol than the other way around, right? Maybe some of the side effects around headaches. So that was the main finding. Now, if you drill down into that paper, there may be opportunities there to say that with a much larger population, there could be some differences between labetalol and nifedipine. And until this day, we were having a discussion at dinner yesterday. The WHO still identifies nifedipine as associated with an increased risk of preeclampsia. We didn't see that significantly here, but when I look at it, there's still more preeclampsia in the nifedipine group, modest, than in the labetalol group. So ongoing questions, and we have a concept we're working on to see how, whether we can further evaluate this in an international setting. Treatment goal, is Dr. Bailey here, Erin Bailey, in the room? All right, she's on service. Okay, well, as a fellow, she worked with Dr. Hoppe and had a fellows a plenary presentation on this sub-analysis. Amazing, looking at whether treating now to a goal less than 130/80, consistent with the new guidelines that came up while the trial was going on. So this wasn't a randomized intervention, but we looked at that and it was remarkable how the outcomes were lower in those whose goals, on average, blood pressures were less than 130/80 as compared to 140, even almost as much as a 50% difference. Obviously, that could also be tied in with some bias where perhaps those patients already had lower blood pressures to start with compared to those that ended at 140/90. And so it may be a reflection of their own blood pressures as opposed to the actual intervention. So a trial will need to be done to tease that out, but it's very promising, and that's where we started with CHAP2. So there is a grant, a PCORI grant, that when it was proposed to the MFMU network, they didn't bite on it. We said, okay. And one of our colleagues is leading this PCORI grant that we are waiting to hear about to see whether a trial could be mounted to treat those with chronic hypertension to a lower goal. We also have ongoing a study that one of my other mentees is working on, where we are looking at patients who have this stage 1 hypertension only and treating them to a goal less than 130/80 as a pilot study. And so we're waiting to see those results. We have long-term studies going on. The mothers, following them for severe cardiovascular disease and development of severe chronic hypertension. That's in its 5th year. So I'm hoping by the end of this year or sometime next year, we'll have those results to see how these patients, women, mothers did longer term with respect to the intervention and with respect to preeclampsia at that index pregnancy. And then we are also following up the children for neurodevelopment and growth. And that's it's about to start its 4th year of 5. We also have a preeclampsia epigenetic study that was mounted based on all those specimens that were collected, looking at prediction of preeclampsia and all that based on epigenetic markers, and that is completed and results will be available. Some of the specimens that we collected have been transferred to an NHLBI mechanism called TopMed. It's called Transomics for Precision Medicine. It's a huge resource that brings in studies and samples, and they do all kinds of genetic, whole genome sequencing, transcriptomics, proteomics, all kinds of testing, and it's available to the public subsequently to do all kinds of basic studies around hypertension and pregnancy. And a K mentee looked at some of these blood specimens, and it's working on identifying, measuring lipid levels of cholesterol and other lipids and correlating those by trimester to outcomes. So those results will be available. And also another mentee submitted a care grant and is currently looking at the kids to evaluate whether there are childhood subclinical cardiovascular risks that can be traced back to the intervention or to preeclampsia. And then finally, this was all done with chronic hypertension, but what about gestational hypertension and what about preeclampsia? Should we automatically just apply the CHAP results to those categories? I know that's a huge debate going on, and I think ECOG still sticks with looking for the evidence. And so a colleague submitted a K23 and did a very small study evaluating that, and that has now been translated into a huge trial that will enroll 4,300 at the MFMU network to address that question. The protocol is just being completed, and the goal is to launch that trial later this year. So that is coming. All right, well, thank you so much for the opportunity to be here, and I'm happy to take any questions if there is time. Thank you.
Thank you so much. I just absolutely loved your talk, and I think it just exemplifies kind of how you have to take observations and mechanisms that we know from outside of pregnancy and to make sure that we actually do the right studies in the context of pregnancy. And I'm so happy that both you and the team have kind of undertaken projects like this in order to advance what we do on OB/GYN. There's a question, I promise.
Yeah. So thank you.
Yeah. Yeah. So in that context, by treating hypertension, right, you're sort of modifying one of the main mechanisms of kind of endothelial damage potentially and sort of ill effects that lead to severe preeclampsia and sort of those sorts of outcomes. Have you looked at, I know that the Germans, and there's been sort of a few other trials out there doing things like plasmapheresis, or specific kind of depletion of some of the molecular factors that relate to preeclampsia. Have you considered integrating them with these trials?
So that's a really great question. And we had the group of Ananth Karumanchi, who does some of this work around angiogenic markers, reach out to evaluate, look at the blood specimens and evaluate those markers to correlate to the our findings. And unfortunately, it's not my decision. There is a protocol and publications group that did not look at that proposal to say that it was good for this. So we've not done that. There is another study that's led out of Oklahoma where they have specimens as a pilot, and they're going to look at another biomarker to see whether there is correlation between that biomarker and preeclampsia as well as our findings. So there is an opportunity here, and those we have blood specimens. I think there will be an additional opportunity with this TopMed process because all the specimens we have, samples have been sent, and this I think comprehensive testing will allow people to get at some of these additional hypotheses. So, thank you. All right, well, thank you.
Rachel Mojdeh-Bash is our graduating fellow in GYN oncology this year and has been a part of our department since June 2019 when she joined us as a resident. And much has happened in that time, including that Rachel has been a part of 7 publications during her time here. The most recent one published just this month. 7 oral presentations at scientific meetings and 11 poster abstracts at scientific meetings. During her fellowship, she was also a Birch Women's Health Scholar, prestigious award and program administered by the Office for Research on Women's Health at the NIH. I'm very excited to listen to her presentation this morning and just a part of the research she's done during her time here at UW.
All right, good morning, everyone. Thanks for being here today. So I'm here to talk about a project I completed titled An Estrogen Receptor Pathway Activity Score to Predict Response to Hormonal Treatment in Endometrial Cancer. So how do we treat endometrial cancer? There are 3 main treatment buckets we can take from: surgery, radiation, and systemic therapies, which can include chemotherapy, immunotherapy, and hormonal therapies, among others. These systemic therapies use numerous cellular pathways to impact cancer cell survival. Hormonal therapies specifically take advantage of hormonal signaling pathways shown here. The more common subtypes of endometrial cancer are driven by estrogen-mediated growth of cells. Therefore, anti-estrogen hormonal therapies can be used as treatment. Progestins such as megestrol acetate and medroxyprogesterone acetate can be used. They work by turning off estrogen-driven growth signals, slowing cell cycles, and encouraging cells to behave more normally. Tamoxifen can be used to paradoxically in endometrial cancer by increasing progesterone receptor expression and making cells more responsive to progestins that are also used in combination with progestins. And aromatase inhibitors can block estrogen creation through blocking aromatase. Response rates to these therapies range anywhere from 15 to 30%, which is not bad, but it's also not great. So when do we use them? We use hormonal therapies most often in the recurrent setting of endometrial cancer when response rates for all systemic therapies begin to decrease. We can also use them when surgery or other more toxic therapies are not good options for a patient. So what's the issue? The truth is, recommendations for using hormonal treatment for advanced or recurrent endometrial cancer are not well defined, and there remains large variation in predicted response in these patients. Anecdotally, sometimes it works well and sometimes it doesn't. So what's contributing to the lack of understanding and standardization of this treatment? One issue is how we measure the positivity of estrogen receptors. We measure estrogen receptor positivity of a cell by staining the receptors on the tumor tissue, a process called immunohistochemistry. IHC expression does not provide information about the functional activity of the estrogen receptor signaling pathway, and hence does not reflect hormone-driven tumor growth. We also use positivity cutoffs for clinical significance based on breast cancer research, another hormonally driven disease. We have no endometrial cancer guidance for what receptor thresholds are relevant and may confer different response rates. This group in the Netherlands posited that expression levels of estrogen receptors and progesterone receptors as determined by IHC are established prognostic markers for endometrial cancer, as in the loss of these receptors is associated with increased risk of lymph node metastases and recurrence. But they also published a novel approach to measure estrogen receptor signaling pathway activity using a knowledge-based Bayesian computational model that infers functional activity of the pathway from the expression of mRNA-encoded estrogen receptor target genes. This score has also been proven to predict response to hormonal therapy in breast cancer. What did they find? They found that estrogen receptor pathway scores varied significantly with the menstrual cycle, which validated their score. High activity scores were associated with proliferative and hyperplastic endometrial tissue. Low activity scores were associated with stage 2 through 4 endometrioid adenocarcinoma and serous adenocarcinoma. And low scores also were associated with recurrence. We wanted to see if, number one, we could replicate this score using the model they published, but without the commercial test that they used, and also see if we could predict response to hormonal therapies in archived endometrial cancer tumors treated with hormonal therapy by correlating clinical outcomes. We first aimed to replicate this Bayesian model. We trained the model with one data set and validated it with another. At the same time, we identified endometrial cancer patients with archived tumor and performed bulk RNA sequencing on this tissue. We then tested the model on our data, on our own data. We also collected clinical outcomes and analyzed the scores with these. Here's a graphic of a Bayesian model. Bayesian models combined prior knowledge such as previous studies, biologic understanding, or clinical expectations with new patient or experimental data to estimate what is most likely true. So here we had a set of genes, on the right is a portion of them, involved in the estrogen receptor pathway that we predicted would be up or down regulated when activated. And when actual genetic data was inputted, the model came up with a score of how active the pathway was in that tumor. We trained the model using publicly available data, a data set of cells exposed to estrogen in step 1. We then validated this with a TCGA data set of endometrial cancer patients, and finally tested it on our own patient data. We included 29 samples from the surgical archives of recurrent endometrial cancer who had been treated with hormonal therapy. RNA was isolated and sequenced in-house, and chart reviews completed to record clinical outcomes. All the included samples were recurrent endometrioid histology and treated with one of these hormonal therapies at some point in their treatment course. 16 of the 29 patients had died at the time of analysis. 7 had a complete response, 4 had stable disease, and 17 had progressed. This is a violin plot of the estrogen receptor pathway activity score on the y-axis and disease status at the time of analysis on the x-axis. You can see that those with a complete response in blue did have a higher score than those who progressed in red, with stable disease being in the middle. Patients with a clinical response, which we defined as complete or stable disease, had a mean score of 3.2, and patients with progressive disease had a mean score of 1.8, which did not end up being a significant difference. Here, when we compared the score to those alive or dead at the time of analysis, the score was higher in the living group. We also calculated a Kaplan-Meier curve to illustrate survival, which was significantly higher in the high score group. Furthermore, when we break the disease into grades, a lower grade being in theory a more normally functioning cell, we saw that the activity score behaved accordingly. A lower grade had a higher score, and a higher grade had a lower score. We also wanted to correlate the activity score with the standard way of measuring estrogen positivity in a cell, IHC, previously mentioned. We found similar results to the Netherlands group with a positive estrogen receptor by IHC correlating with a higher activity score. So to conclude, we successfully adapted a molecularly informed estrogen receptor pathway activity score published by one other institution using bulk RNA sequencing data and independent cell line validation, allowing us to calculate this score in-house without the use of commercial platforms. We also successfully correlated the estrogen receptor activity pathway score to meaningful clinical outcomes. Patients who had a clinical response to hormonal therapy did have higher scores. Our experience adds to the limited data on this novel score and also demonstrates the ability to calculate the score with different molecular inputs, which may expand its accessibility. Some next steps may include exploration of other hormonal pathways and their associated genes, since we do have bulk RNA sequencing data of these tissues, of these tumors. We should also investigate this score in other histologies beside the endometrioid type. and also perform the score on larger retrospective or prospective cohorts to more clearly attribute a hormonal therapy effect to disease response. In general, we're moving towards more targeted therapies and classifying cancers based on molecular profiles as opposed to pathological histologies. This score fits into this goal and provides an opportunity to more specifically target patients who may benefit from hormonal therapy. I want to thank my mentors. Dr. Barolette has given so much to me, but importantly for this project, helped me apply for a Birch grant. Dr. McGregor, without whom I would not have tissue to sequence. Dr. Patankar, taught me so much about RNA sequencing and translational research. AJ Fagan, our statistician, without whom this project would not exist due to my inability to actually understand Bayesian models. And all of the members of the Barolette and Patankar lab who had great suggestions and feedback and also helped complete the critical bench portions of this project. I appreciate all of your help. Thank you very much. Happy to take questions.
That was great. I'm wondering how you would approach a prospective validation of this work. Money is no object.
Yeah, so I think, a lot of questions have come up throughout this. I think it's really interesting to understand what these scores look like in a primary diagnosis, because we know that tumors change when they recur. So if we had an opportunity to get scores on primary tumors, then again, when they recurred, and then also be able to look at those scores before and after hormonal treatment specifically. So I alluded to it, but a lot of these patients in their recurrence had a combination of radiation, chemotherapy, hormonal therapy. So it's impossible to parse apart those differences. So I think if we could actually test and see what hormonal therapy does alone, that would be wonderful.
Thank you so much. I'm really excited for you. You're joining a really fabulous department.
Thank you.
Although we're, so sad that you're no longer going to be here. But two questions actually. One is, how much do you think variability in receptor expression between different cells within a tumor matters in the context of either prognosis, as well as, kind of long-term impact of this type of grading? And then two, do you think there's going to be any ways to do some of this work through kind of liquid biopsy approaches before even surgery and things like that?
Good question. So yeah, I think there is, I learned a little bit in my time in the Barolette and Patankar lab about like the spatial heterogeneity of tumors and how you can do sequencing and actually kind of map spatially how the sequencing changes within a tumor itself. I think it's super interesting and probably does play a role. These are obviously, this is one portion of one slide of one tumor. So this is like a very limited sample. Liquid biopsy, I think it would be possible, like as long as you have, it would be obviously a more accessible source. And if you had tumor cells, you could do the sequencing and perform the score in hopefully a more time efficient way that I did. But I think that it is definitely possible to do that. Will be, yeah. Thank you.
Good morning. I have the pleasure of introducing our next presenter, our third-year maternal fetal medicine fellow, Dr. Jackie Powell. Dr. Powell completed med school at MCW and her residency at Oregon Health and Science University before she joined us for her MFM fellowship. Dr. Powell's thesis project has evaluated maternal morbidity during major public health events in the state of Wisconsin. Dr. Powell is very involved in advocacy. She's on the Wisconsin State Maternal Mortality Review Team, very involved in ACOG, and is really committed to improving the health of pregnant patients. So welcome, Dr. Powell.
All right, good morning, everyone. I am happy to present my thesis work for you today. No relevant disclosures. This was funded through our department's fellowship thesis fund, which I'm really grateful for. Background will define severe maternal morbidity. So the CDC defines SMM as 21 ICD-10 codes that represent potentially life-threatening medical conditions. The definition of SMM has been used as a data measure to evaluate morbidity trends, and this composite outcome is important to evaluate as it's a critical pathway to maternal mortality reduction. The most recent data nationwide shows that the overall rate of severe maternal morbidity increased 40% from 2016 to 2021, and in the absence of COVID-19 diagnoses, SMM increased by 21%. In Wisconsin, the rates of SMM have mirrored national trends with a 30% increase from 2016 to 2023, and the most recent published rate being 77.9 per 10,000 delivery hospitalizations in 2023. Geographic location can affect SMM rates, with rural areas experiencing increased rates of SMM compared to urban areas when looking at nationwide studies. In Wisconsin, 25% of people live in rural areas and 16% live in rural adjacent areas. COVID-19 increased many risks during pregnancy, and I don't think I need to elaborate on that for this audience, as this is well defined. Some may wonder why it's still useful to look at outcomes during COVID-19, given all that we know already, but I view this time period just as we view pregnancy as a stress test on someone's health. Analyzing population health level outcomes during the pandemic can help us identify weaknesses within our healthcare system when it is under stress, and thus highlight areas for interventions to strengthen our healthcare system in Wisconsin. The Dobbs decision is also a key public health event that occurred over the past few years. Abortion access can affect SMM if patients who may be medically complex and have significant pregnancy risk are not able to access abortion and are forced to continue a pregnancy they might otherwise not have. So our objective was to determine the overall rate of severe maternal morbidity in Wisconsin during the COVID-19 pandemic and in the period following the Dobbs decision, to generate evidence to guide program and policy interventions to improve perinatal health during public health emergencies. So our primary aim was to determine the overall rate of SMM during COVID-19 pandemic and after the Dobbs decision, with our hypothesis being that the rate of SMM would increase during the pandemic and after the Dobbs decision. Our secondary aim was to determine geographic differences in the rate of SMM during these time periods, with our hypothesis being that rural areas would be more impacted by increased SMM rates during these time periods. And our tertiary aim was to analyze the rate of individual qualifying diagnoses for SMM during these time periods, and this was an exploratory analysis. We performed a retrospective cohort study and worked with the Wisconsin Hospital Association to build our data set. Wisconsin Hospital Association collects discharge data for all inpatient admissions across Wisconsin. We requested records for any patient with a diagnosis-related group code for both vaginal deliveries and cesarean deliveries during the timeframes listed here. Because of the nature of discharge data, we needed to specifically request diagnostic codes for any diagnoses that we wanted included in the data set. So we include all codes that were part of the SMM composite. Our study periods for pre-COVID was March 1st of 2017 to February 29th of 2020. And then during COVID was March 1st of 2020 to March 31st of 2023. This is based on when the WHO declared COVID a pandemic and when it stated that the pandemic ended, but knowing that our dates are slightly different because we were only able to obtain our data in quarterly timeframes. Pre-Dobbs was defined as January 1st of 2021 to June 23rd of 2022. And then post-Dobbs was June 24th of 2022 to June 30th of 2024. The post-Dobbs timeframe was extended beyond September 23 when abortion restrictions resumed to accurately reflect second and third trimester pregnancy outcomes for those who may have been in their first trimester during this restricted period when the Dobbs decision was still in effect. For our statistical analysis, demographic data by period were tabulated using number and percent. Differences between periods were assessed using Pearson's chi-square test. SMM rates were estimated using regression models, and generalized additive logistic regression models were used to model changes in SMM as the rate of function, time, and geographic location. So for the COVID time period, there were 334,366 births overall. Just over 172,000 were pre-pandemic and 161,000 during the pandemic. Race and ethnicity distributions differed significantly between the time periods, while payer and spoken language distributions did not differ significantly. Overall, there were 2,210 severe maternal morbidity events during this time period at a rate of 0.7%. There was a significant increase in SMM events during the pandemic, with 0.6% of all delivery hospitalizations having SMM events pre-pandemic and 0.8% of all delivery hospitalizations experienced them during the pandemic, with a relative risk of 1.33. There was no evidence of geographic variation on the impact of the pandemic and the rate of SMM. This figure on the left-hand side of the screen shows zip code specific rate ratios for severe maternal morbidity, comparing the COVID-19 pandemic period to the pre-pandemic period. So yellow boxes indicate elevated rates during the pandemic. Purple indicates lower rates during the pandemic. Points are plotted at the zip code, centroids, and point size reflects total number of births. I already discussed severe maternal morbidity as a composite, but these are the individual diagnoses that make up the definition. And so what we would expect during COVID-19 for all patients, the incidence of several diagnoses increased significantly, including acute myocardial infarction, acute renal failure, respiratory distress syndrome, cardiac arrest and ventricular fibrillation, DIC, anesthesia complications, sepsis, shock, and need for ventilation. For our Dobbs time period, there were 186,749 births in this study period, just over 80,000 pre-Dobbs, and 106,000 post-Dobbs. Across all characteristics, distributions differed significantly between the pre and post-Dobbs group. Generally, these distributions look pretty equal to me, so I believe that this is secondary to the large sample size. Overall, there were 1,453 SMM events. The rate of SMM increased from 0.7 pre-Dobbs to 0.8 post-Dobbs, but this was not statistically significant. There were no significant geographic variations on the pandemic's impact on SMM rates. The figure here is similar to the last slide, showing our zip code specific rate ratios. For all patients, the incidence of 2 diagnoses increased significantly after the Dobbs decision compared to pre-Dobbs. Sepsis increased from 69 to 129 cases, and shock increased from 52 cases to 117 cases. So our data shows the strong evidence that the COVID-19 pandemic was associated with an increase in SMM events. However, there was no evidence of geographic variation. This parallels the severe maternal morbidity rates that are increasing nationwide with a marked increase during COVID-19. In Wisconsin, our Department of Health Services published that the rate of SMM in 2023 was 77.9 per 10,000 delivery hospitalizations, which is very similar to the rate that we found between 2020 and 2023, which was 0.8 of all delivery hospitalizations. Thus, this validates our data set for future research. What is more thought-provoking is the lack of geographic variation, given we previously established that trends of SMM in rural areas are worse compared to urban areas. There are a variety of reasons that we can explain why we didn't see a geographic variation. One of which is overall access to care in Wisconsin. While there were 8 obstetric unit closures during the study time period, there were 2 rural hospitals that began offering labor and delivery services between 2018 and 2022. Additionally, while only 48% of Wisconsin's critical access hospitals offer obstetric services, this is higher than the national average of 40%. Our relative increased access to care could have attenuated an increased risk of SMM in rural areas. Furthermore, our data could suggest that our Wisconsin transfer system is very effective. However, to the best of my knowledge, prior studies have not evaluated this. It is also possible that our lack of geographic variation is due to the relative rarity of SMM incidence. The low frequency in rural areas could have attenuated our ability to identify statistically significant trends. From the Dobbs perspective, the lack of difference in overall SMM rate and geographic variation could be due to a variety of reasons. Data continues to emerge on the effects of the Dobbs decision on severe maternal morbidity. Public policy changes often have long-standing effects after policies are reversed, and thus it's challenging to capture the true effects of these types of changes within short time periods. Our data is just one piece of the puzzle in the setting, and continued analysis will be needed. Wisconsin also has a referral system in place, and some patients were able to go to neighboring states for termination. Thus, that potentially could have attenuated an increase in severe maternal morbidity. Even though we designed our time periods to hopefully avoid the effects of COVID-19 on SMM rates during the pre-Dobbs time period, 2021 was still a year where we saw significant maternal morbidity from COVID, and thus a higher rate during this time frame could contribute to the lack of difference that we found. When we look at our results in the context of what is known, data from other states also shows varied results. A retrospective study out of Utah that was published in 2026 noted no change in the rate of severe early pregnancy morbidity after Dobbs. However, in states with higher number of abortion-restricted policies, had a 7% increase in maternal mortality compared to less restrictive states. So overall, this is complex. There are many components to abortion bans and abortion access. Not only do these policies affect immediate access to care, but they also affect physician recruitment and retainment in restrictive states. So our data in the context adds to the growing evidence, and I suspect that the effects of the Dobbs decision are not isolated to the time period that we studied. Our findings of increased rates of sepsis and shock during this time period of abortion restriction is additionally complex. Similar findings were seen in Texas after their abortion ban was enacted. However, there are some key differences in that we were able to continue providing termination for periviable PPROM, which is a key cause of the obstetric sepsis and shock. While there are other causes of obstetric shock, such as pyelonephritis and transamniotic infection, we wouldn't expect these to be directly affected by termination bans as much as periviable PPROM, except for the fact that if sicker patients were continuing pregnancies, they would be at higher risk for these complications. Even though we were able to continue providing termination for periviable PPROM at Meritor, this is not the case statewide. Fear surrounding legal implications could have affected how rural patients were able to access care, leading to either delayed treatment or lack of delayed referrals, lack of counseling surrounding pregnancy options, all due to fear of legal implications. So briefly, as I believe my time is up, our key take-home points today is that SMM increased during COVID-19, but there was no geographic variation, suggesting that our Wisconsin healthcare system for obstetric patients can withstand the stress on the healthcare system during pandemics. Severe maternal morbidity was not affected by the Dobbs decision overall or geographic variation, but sepsis and shock were significantly increased. Wisconsin data mirrors national trends, and this data set is validated for future research studies. Briefly, our strengths was a large sample size and that we could include many births across Wisconsin. A few limitations would include information and measurement bias due to the nature of the data set. The challenges with our time periods, as I briefly mentioned, and the fact that the infrequent nature of severe maternal morbidity events, especially in rural areas, could have attenuated findings that we were expecting. I'd like to acknowledge Dr. Hoppe, who is a primary mentor for this work, and without her, I would not have been able to complete this. And I learned so much throughout this process of really kind of starting from building a data set to taking the project to the finish line. Dr. Rhodes, who was a vital mentor throughout all of this thesis work and fellowship, and Dr. Gagnon, who performed the statistical analysis and played a vital role. Allie and Michelle are two medical students who have done some projects that have been branches off of this work, and then of course my co-fellows.
Nice job, congratulations. Yeah. So I was wondering, you made allusion to this, but I was wondering whether there are certain ways you could tease out the effect of COVID-19 and the effect of, Dobbs. For example, COVID-19, everyone was susceptible to, but for Dobbs, there are some ways to restrict to a particular population that may be more susceptible to the Dobbs or subgroup to the Dobbs the consequences of Dobbs. Then the relative risks you presented, were those adjusted for anything?
Sure.
Yeah, nice job.
Thank you. So to answer the first question, we have thought about narrowing our time frame for our pre-Dobbs interval, so narrowing it to just the 6 months prior to the Dobbs decision. So that would include data from just the first half of 2022. And hopefully that would potentially see if we can eliminate some of the effect of COVID, knowing that COVID was more prevalent in 2021 compared to 2022. So that's one thing that we have thought about doing from that standpoint. And then, unfortunately, because of the nature of the data set, we don't have all like medical diagnoses or medical conditions for patients. So truly, we only had our SMM indicators and then a few demographic variables, including like payer status, race and ethnicity, spoken language, but we weren't able to have like hypertension, renal conditions, BMI, age, parity, just because we had to request every single variable. And so we needed to kind of really narrow it down from that standpoint. And so to be able to kind of tease apart who is more susceptible to COVID versus not, we're limited because we don't have those detailed individual patient characteristics. And then for your second question, we were only able to, because we didn't have all of those different medical diagnoses for patients, we were not able to control for things like hypertension and kidney disease, et cetera. So it was really just our demographic variables that we had. Yeah. Dr. Cutler.
Thanks so much, Dr. Powell. I found obviously your post-Dobbs findings really interesting, and you had shared some of them with me prior. I thought it was really compelling, this idea that the state's referral system could have explained how patients were getting the care that they needed, despite the restrictions. I think it's really worth examining what that referral system entailed, because based on some research done by multiple faculty in our department out of core, that referral system was really inadequate, especially across like certain areas of the state. And so the referrals were happening, but how, I think, is worth understanding. And I invite everybody to come to poster number 20 if you want to learn more about that.
Absolutely. Thank you. And we have some follow-up ideas for our Dobbs analysis, especially when kind of looking at the sepsis and shock outcomes. And what I would like to do would be to determine which hospitals, were still able to provide services for determination for things like life-endangering events and peri-viable PPROM, and who determined that that was enough of a life-endangering event to be able to continue that. I think that might be challenging, but was one of the things that I thought about. If we could see which hospitals were still able to provide those services or to be able to provide that counseling, and then be able to, because we have all of the delivery hospitals in our data set, and to be able to analyze it from that standpoint, because the locations that we have for this research is all location of residence, and it's not location of delivery. And so that is something that we would like to look at as well. And of course, optimistic about the ability for us to live close by to Minnesota and Illinois, but recognizing that the feasibility of some of the referrals is not always there. So thank you for your comment.
Thanks so much, Dr. Powell. Really appreciate this presentation. I have lots of follow-up questions for you and thoughts. One, do you feel as if the main issue behind your lack of significance was power, right? I mean, as you said, they're rare events. One of the reasons that researchers have had to look nationally at the effect of Dobbs on, say, maternal mortality is that maternal mortality is a relatively rare event. So I was wondering if you and Ron and your biostats colleagues feel as if maybe this is just a power issue. And my other question is, would you consider also examining depression as an outcome to see if there's anything there?
Yeah, absolutely. Thank you for your comments. I do think that power might be an issue, because these mean, fortunately, these SMM events are rare outcomes. And when you look at short time periods and you are kind of narrowing those outcomes even further, then I think there's a potential to miss actually true trends that are there just because we're not able to find the true statistical significance. So one thing that I have thought about is, well, now that we know that this data set can be used and is validated, as we have similar findings to what Department of Health Services has found, is that we could look over longer time periods. But recognizing the issue with that is that we know that the SMM rate is changing, it's increasing. And so then when we find differences over longer time periods, is it because our SMM rate is increasing because our patients are getting pregnant older with more medical complications? Or is it actually true trends that could reflect other events that have happened? And then for looking at depression, I think that's a great idea. I think what we can do with this data set would be to go back and then ask for the specific diagnoses that could fit the ICD-10 codes that would fit with depression. But the way that this data set works is you really have to specify the exact diagnoses that you want. And you can only, there's a limit to that. But I think for further research, that would be really interesting to look at. Thank you.
Okay, thank you.
Good morning. I'm delighted to introduce Dr. Kelly Stewart for her URPS thesis defense on Research Day. Dr. Kelly Stewart completed her combined BS MD at the University of New Mexico and then went on to the University of Texas Medical Branch in Galveston, Texas, where she completed her OBGYN residency. She joined us as the final to our full complement in the URPS fellowship and will complete the fellowship in July of this year, after which time she will then join the University of Arizona banner in Tucson, Arizona as an academic urogynecologist. I'm delighted to have her present her results from depression and trauma symptoms after obstetric anal sphincter injury. Please welcome Dr. Kelly Stewart.
Good morning. I'm presenting a pilot study that we performed in our subspecialty urogynecology perineal laceration clinic. I performed this study with one of our advanced practice providers, Maureen Sheets, which I'm eternally grateful for, and also Dr. Pennycuff. Starting with her background, obstetric anal sphincter injury, or OAC, as I refer them to, is a severe perineal laceration involving the anal sphincter complex. We also call these 3rd and 4th degree perineal lacerations. The estimated incidence is about 4%. And subspecialty perineal laceration clinics have now merged academic institutions to provide early individualized care to women with OAC. And these clinic visits do provide a unique opportunity to address significant short and long-term sequelae of OAC, most notably short-term sequelae like wound complications, which we know have a high risk of breakdown up to 20% and also a high risk of infection up to 25%. And then long-term sequelae include pelvic floor disorders like anal incontinence, as well as pelvic organ prolapse, fistula formation, and sexual dysfunction. But it's also thought that OAC could have a significant impact on maternal mental health, but unfortunately we don't have much data to show the relationship between OAC and maternal mental health. A recent retrospective cohort study found that patients with OAC wound complications may be at a higher risk for screening positive for postpartum depression. A cross-sectional survey also identified a 3rd or a 4th degree perineal laceration to be a risk factor for childbirth-related post-traumatic stress disorder. And then a secondary analysis of a large database study showed that the degree of a perineal tear was significantly associated with childbirth-related post-traumatic stress disorders at 8 weeks and also at 2 years postpartum. So the overall prevalence of postpartum depression is thought to be around 14% in the United States. And then the prevalence of not prevalence, sorry, Dr. Fedico, prevalence, that's my Southern accent coming out. The prevalence of childbirth-related post-traumatic stress disorder is thought to be overall 5% in mothers, but a study found that up to 16 to 19% for higher stressor intensity, such as premature births, stillbirths, or severe obstetric complications like OAC. And so overall, my question was, should we be screening for postpartum depression and childbirth-related post-traumatic stress disorder in subspecialty perineal laceration clinics? So our primary objective was to determine the prevalence of postpartum depression and childbirth-related post-traumatic stress disorder symptoms in patients with OAC. And then secondary was to determine if there's an association between postpartum depression and childbirth-related post-traumatic stress disorder with OAC wound complications, or if there's any association with pain scores at delivery or at a patient's clinic visit. So we had an IRB-approved prospective cross-sectional pilot study. It was performed in a single-site subspecialty perineal laceration clinic from July 2025 through March 2026. And we included patients who underwent a vaginal delivery complicated by OAC within 2 months of their initial clinic visit. Subjects completed validated screening questionnaires for postpartum depression and post-traumatic stress disorder. So the first was the Edinburgh Postnatal Depression Scale. A positive screen was considered a score of 11 or higher. And then the post-traumatic stress disorder checklist for DSM-5, which we are all less familiar with. It's abbreviated PCL-5. It's a 20-item self-report questionnaire with a score range of 0 to 80, and a positive screen is considered a score of 31 or higher. Patients also completed a supplemental question regarding pain experienced during delivery using a visual analog scale. And then we did do an electronic medical record review for demographics, medical history, delivery details, pain scored during their initial clinic visit within our subspecialty perineal laceration clinic, and then also looking at OAC wound complications. For statistical analysis, we obviously did descriptive, but then we utilized Fisher's exact test and Mann-Whitney when applicable, and then also attempted logistic regression. So for our results, we enrolled 55 patients with an 85% participation rate. The mean age was 32 plus or minus 4, and then the majority of these patients were white, up to 89%, and they were also married, 86%. Just overall looking at delivery details for the study group, so at N of 55, the median gravidity and parity was 1. Looking at breakdown of type of OAC, 55% had a 3A, 25% a 3B, 15% 3C, and then 5% had a 4th degree. And for operative vaginal delivery, 35% of these patients had an operative, with the majority of having a forceps delivery if they had an operative vaginal delivery. Looking at OAC wound complications for the study group, so 4% had a perineal infection, 13% had a breakdown, and at the time of chart review, none had had a surgical revision. For pain scores, so median pain score that patients reported during their delivery was 7, and then the median pain score that the patient reported as like a vital sign during their initial clinic visit was 1. So for our primary objective, 18% screen positive for postpartum depression and 6% screen positive for post-traumatic stress disorder. And so to look more at the EPDS, the Edinburgh Postnatal Item Response Patterns, we put this in a heat map. And so over 80% of patients selected item 6, which read, "Things have been getting on top of me," which isn't surprising when you have a newborn. But for item 3 and 4, over 2/3 of patients selected some degree of bother. Item 3 was, "I have blamed myself unnecessarily when things went wrong." And item 4 was, "I am anxious or worried for no reason." And then we also developed a heat map for the PCL-5 item responses from the patients. Almost 50% of patients selected some degree of bother for item 13, which was feeling distant or cut off from people. And then item 17 was being super alert, watchful, or on guard. And so since 18% of the study population did screen positive for postpartum depression, I attempted to look more into separating them into 2 groups based on EPDS cutoff score. And so using a Fisher's exact test, we did find a significant finding showing an association between use of anxiety or depression medication before pregnancy and screening positive for postpartum depression. Another significant finding was a possible association between a higher degree of OAC, like a 3C or 4, and also screening positive for postpartum depression. Looking at an association with OAC womb complications, we did not find one. And we also found that there was no difference in pain scores between patients who did and did not screen positive for postpartum depression. And then attempting a logistic regression, trying to see if we could find a predictor potentially for a patient after OAC screening positive for postpartum depression, like a prior diagnosis of anxiety or depression, or either of their pain scores, either at delivery or during a clinic visit. There was none of these variables were found to be predictors. Discussion. So overall, the prevalence of postpartum depression symptoms may be higher after OAC than in the general postpartum population. The prevalence of childbirth-related trauma symptoms after OAC was overall low, but it's not negligible. The use of depression or anxiety medication before pregnancy may be associated with screening positive for postpartum depression after OAC, and then a higher degree of a perineal tear may be associated also with screening positive for postpartum depression. So limitations, obviously this was a pilot study, it was a small sample size. It also was a convenient sample, so we were only recruiting patients from their first clinic visit in our subspecialty clinic. And then with these patients, they had self-selection and also recall bias about their delivery. And then these mental health questionnaires, they are self-reported, so they will never compare to a clinical diagnosis by a psychiatrist. And there also is instrument bias, so this leads to the question of, does the PCL5 questionnaire appropriately capture childbirth-related post-traumatic stress disorder symptoms? And so an example of this would be how the Edinburgh postnatal depression scale was developed instead of using, a general depression questionnaire like the PHQ-9. And so should we be developing a more specific questionnaire to look at trauma symptoms for the postpartum population? The EPDS and the PCL5 questionnaire response patterns do provide some insight into counseling and providing some reassurance for patients after OAC. And overall, I think in subspecialty laceration clinics, we do have an additional opportunity to screen for postpartum mental health disorders. I'll take any questions if there are any. I only said prevalence like once. I think I was good. I think I was pretty good. Yeah. Okay, good.
Good morning, everyone. Thank you for joining us at our Department Research Day. It's great to see outstanding presentations from our presenters. I would like to take a moment to first thank our research leadership team, our chair, Dr. Hartenbach, and our vice chairs, Dr. Hoppe and Dr. Stanek, for their continued support and guidance in our research work here. I want to highlight a few things about our research office. We have 5 cores to support the research work. We have dedicated staff in these cores, human subjects core, sponsored projects and finance core, tissue collection and processing core, data management and statistics core, and the training grant core. Over the past year, we have continued to grow in important ways, expanding our clinical trials, especially industry-sponsored trials, increasing high-impact publications, doubling our grant submission, strengthening interdisciplinary partnerships, and increasing engagement of our trainees and early career investigators. These accomplishments reflect the contributions from the faculty, the trainees, the staff, and collaborators working together to accomplish the research mission. This next session is actually a reflection of this collaborative spirit. Our poster session highlights the breadth of work in our department, and we had a strong response this year for the call for submission. We received submissions from all divisions, including from residents, fellows, faculty, trainees, and staff. And we encourage you all to take this time to connect with the presenters and ask questions, engage with them, and definitely make new connections. This is where some best ideas and future collaborations begin. So the event coordinators have grouped the posters in 9 categories. This is to encourage engagement and discussion. So please go ahead and make connections at the hall, and please return back here for Dr. Sharma's presentation at 10:10. Thank you.
Welcome back, everybody, for the second session of our research day. It's my pleasure to introduce Sejal Sharma. She was a grad student in my lab. She's a grad student in the ERP program and did her doctoral research in my lab. Her focus for her research was on developing novel therapies for ovarian cancer. So she's going to talk about one of those projects that we have in collaboration with Jack Gallipo's lab here at UW. Sejal is traveling today, so she is joining us online. Sejal, go ahead.
Thank you, Manish, for the introduction. And thank you, everyone, for joining today. Unfortunately, I could not make it in person. And because of my timeline, I will be able to give a short talk. And if you have any questions, we can discuss on email or, once I'm back. But yeah, excited to talk about my research titled Autologous Cell-Based Vaccine expressing IL-61 fusion protein that drives robust anti-tumor response against ovarian cancer. So our lab focuses on high-grade serous ovarian cancer, which is a major form of epithelial ovarian cancer types. There are 4 main stages. The stage 1 is where the cancer is mainly confined to the ovary, followed by stage 2 and 3, where the cancer starts to spread to the pelvic organ, abdomen, lymph nodes, vagina. The stage 4 is the metastatic stage of the disease, where there is involvement of secondary organs. Specifically at stage 4, you start to see formation of ascites, which is a fluid-filled environment in the peritoneal cavity of majority of the patients. It is interesting to know that 55% of the ovarian cancer cases are detected at the advanced stage. And the reason is due to the symptoms, which are of a less serious conditions, and usually females miss them, like abdominal pain, pelvic pain, early satiety, and urinary urgency. And this makes the disease really lethal. So as I mentioned, metastatic disease is at the majority of the level, and that makes the survival rate to be approximately 50%. Specifically in the 2025, we observe more than 60% of the patients who are detected with ovarian cancer eventually die. And that suggests a real need to develop new therapies. So some of the common therapies involves a combination of debulking surgery and chemotherapy with some new targeted therapies as well. However, 70% of the patients after giving this treatment relapse. And that is why, as I said, it is a real need to develop new therapies. So one of the therapies we are really interested in is in collaboration with Dr. Jack Gallipo. He's a PI in the Department of Medicine. His lab has designed and patented fusion proteins called as fusokines. So these fusokines are a combination of 2 cytokines that are fused together. So the first family his lab designed is a combination of GM-CSF and gamma interleukin family, which involves like IL-4, IL-7, IL-15 to form these GIF4, GIF7, and GIF15 fusion proteins. The new class of fusokines that I've been working on, along with these GM-CSF family, is the IL-61. So IL-61 is again a combination of IL-6 and IL-1 beta. Each of these cytokines have a specific role in promoting and expanding T cell activity. And this really gives us an hypothesis that when we combine these two cytokines together, can they hyperactivate or produce a gain of function effect on the T cells, which will eventually have some kind of anti-tumor response. So first we'll see how we design and characterize the IL-61 fusion protein. So we first wanted to see in vitro effects of how IL-61 suggests some gain of function on the T cells. So with the human PBMCs, we designed a human IL-61 form. So we designed two separate forms. One is orientation of IL-6 followed by IL-1 beta, and the second is the IL-1 beta with the IL-6. This was then lentivirally transduced into 293 cells. We collected the media and lysates to check for the protein expression levels of each IL-6 and IL-1 beta. And to do that, we used a Western blot. So what we see here and what we know is that IL-61 in any of these orientation is approximately 37 kilodalton. So once we had the media and the lysates collected, we looked at the IL-1 beta antibody. So if you see, we are able to see the bands in the IL-1 beta IL-6 orientation as well as the IL-61 orientation in the media at 48 hours. However, the IL-6 antibody was not detected in the IL-1 beta IL-6 orientation, suggesting that when the orientation of IL-1 beta and IL-6 is connected, there is some kind of hindrance, and that makes the IL-1 secretion to be undetectable. So keeping this in mind, we decided to use the IL-6 IL-1 beta orientation instead for our future experiments. So as I mentioned, IL-6 and IL-1 beta has a role in activating T cell function. So we first wanted to see if IL-61 has any proliferating effects on the T cell activity. So we first isolated T cells from the healthy donor PBMCs and treated them with the human IL-61. Along with the human IL-61, the other controls that we had was no treatment, IL-6 only, IL-1 beta only, which are our individual controls, and then adding IL-6 and IL-1 beta separately and the conditioned media. So once we treated these T cells with the different conditions, we looked at the proliferation of the T cells by CT-FR dye using flow cytometry. And if you see the M2, which is our non-proliferating population, in the IL-61 group, there is no M2 population or very low fraction of non-proliferating T cells. And then when we quantified the proliferating population of CD4 and CD8 T cells, in the IL-61 group, there was a significantly higher amount of proliferating cells in comparison to the other treatment groups, suggesting that IL-61 has some form of gain of function effect on the proliferation of T cells. We were then interested into if this IL-61 has any changes in the memory-like phenotype of the T cells. So similarly, once we isolated the T cells, activated with Dynabeads in the IL-2, we stained these cells with the CD45-RO antibody and ran a flow cytometry. So when we looked at the whole T cell population, on the x-axis, we have the CD45-RO, and the y-axis is the RA. So when we looked at specifically the RO, which is a memory-like phenotype, the right bottom quadrant, we see an increase in the levels of the CD45-RO population in the IL-61 group in comparison to the other groups. And then we specifically looked at the CD4 memory-like phenotype and CD8 memory-like phenotype cells, which showed an increase, suggesting that IL-61 shows a shift towards the memory phenotype. What we know is that T cells, once they're activated, they eventually undergo exhaustion. So to see if IL-61 prevents that exhaustion, we similarly, what we observed previously, we are able to specifically look at the live dead population, which is to see if there is any apoptosis after treatment with the conditions. And when you look at the bottom left quadrant, there are more live population of T cells in the IL-61 group in comparison to the other individual groups. And when we quantified the data and look at the non-apoptotic, meaning the live CD8 and CD4 T cells in the IL-61 group, we saw a significant increase. Overall, all of this data really suggests that IL-61, when fused together, has a strong effect or gain of function effect on the T cells. And that makes us a strong candidate to be used as an anti-tumor agent. And as we work with ovarian cancer, our step was to really use it for the ovarian cancer treatment. So we plan to deliver this IL-61 fusion protein to the metastatic tumors using engineered tumor cells, meaning that these tumor cells will express IL-61, which will be used as a cell therapy for ovarian cancer. And the reason why we do that is because cytokines are known to have short half-life and also have systemic toxicity. So that might hinder or that might lead to higher toxicities when introduced directly into the bloodstream. So in the ovarian cancer world, we usually work with the ID8 model. So basically ID8 are ovarian cancer cells that are syngeneic to the B6 mice, and they eventually form ovarian tumors. And our goal here, as I mentioned, is to modify these ID8 cells to express the fusion protein, which is our IL-61. And we do that by designing a lentiviral vector, which is transduced into the ID8 cells. These ID8 cells are then checked or validated to express this fusion protein. Once these cells are validated, they're injected back into the mice that has established tumors. So this is basically a cell therapy setting of introducing this fusion protein into the mice that has an established tumor, and is called as an autologous cell therapy approach. And now, because we are working with the mouse model of ovarian cancer, we decided to use an orientation of mouse IL-6 with a linker connected to a mouse IL-1 beta to form a mouse IL-61. Again, using a lentiviral vector, we transduced into the ID8 cells, which is our cell therapy product to be used for the ovarian cancer model. And then we looked at the transduction efficiency by measuring the RFP positive cells, which was pretty high. If you see here, I have the various different groups. So apart from the IL-61, I also have the ID8 cells that only express IL-6, ID8 cells that only express IL-1 beta, and the ID8 EV, which are basically the ID8 cells that has an empty vector as our control for the in vivo assays. We also measured the levels of these cytokines in these cells. So we looked at mouse IL-6 and mouse IL-1 beta by ELISA, and we were able to validate a higher expression of IL-6 and IL-1 beta in these ID8 cells. Once we validated that these cells are expressing fusion proteins, and now they are ready to be used in an in vivo assay. So as I mentioned, we are working with the female B6 mice. So our model was, we first started to work with 6 to 8 weeks old mice. These mice were then injected with the ID8 luciferase cells. So these are basically the parental cells that should form tumors. They were injected intraperitoneally. We then, after 7 days, we checked for the tumor growth to see the baseline. And on day 1, we did an IP injection of these various experimental group of cells that I mentioned before. Once these cells were injected, we imaged them to monitor tumor growth and perform survival curve. I know these are a lot of images, but you would appreciate that we had a good number of mice to really decide and see the effect of these fusion proteins. But I really want you to look at day 21 and day 36 and compare the IL-61 group with other individual treatment groups. And you see that most of the mice in the IL-61 group significantly reduced the tumor growth in comparison to the other groups, showing that IL-61 has a very strong anti-tumor effect in vivo in the ovarian cancer model. And when we quantified this data to look at the normalized ratio of the specific day versus the baseline, we again saw a significant decrease in the tumor growth in the IL-61 group in comparison to the other individual groups. On the right you see that we are comparing IL-61 with IL-1 beta only. And the reason is you see here that there is a significant effect that you also see in the IL-1 beta group. However, that effect is lost and you again start to see an increase in the tumor burden in comparison to the IL-61 group, suggesting that IL-61, when used as a cell therapy, has a strong anti-tumor effect. And when I performed the survival curve, we had a cutoff day of day 120. And on day 120, you see that the IL-61 group has a significantly higher survival. There were 5 mice out of 8 that were still surviving. Otherwise, in the other group, most of the mice died or there were just 1 mouse surviving. But if you see the significance, it is pretty high, suggesting that IL-61 in comparison to the other group had a higher survival and showed a significant delay in the tumor growth and also has a strong anti-tumor efficacy in the ovarian cancer model. It is also exciting for me to say that there were 2 mice in the IL-61 group that showed a completely tumor-free, meaning they showed a very strong tumor complete response. Overall, I would like to summarize by saying that IL-61 shows a strong proliferating effect on the T cells. It also has shows some memory-like phenotype and reduces activation-induced apoptosis. It is exciting to see that the therapeutic vaccine of these ID8 cells that express IL-61 has a strong anti-tumor effect in vivo and also has significant improvement in the survival of mice, with 2 mice showing complete response. This data is very exciting and I'm looking forward to what the lab can do next. But with that, I would like to acknowledge my collaborators, my lab, and my department and funding, and specifically Manish, to really go through this process. And it has been an exciting journey for me. Thank you everyone for listening, and I'm open to any questions.
There is a question in the chat. Can you read that, Sejal, or do you want me to read it out loud?
Let me see. I will try if I can see it on the chat. Yeah, I can see the question. So the question is, any additional analysis post-induced apoptosis to supplement protein construction? No, we did not do any additional analysis to determine the protein. I think what I'm really understanding by the question is, do you want to know if there is proteins after apoptosis? Like, I'm not really clear with that question. No, we did not look at any other supplemental assay to determine the protein construction. Thank you.
Thanks, Sejal.
Thank you.
Morning, everybody. My name is Jenny Higgins, and I direct the Division of Reproductive and Population Health, and I'm really pleased to introduce today's speaker, Dr. Tewolade Adekunle, who's back from who's here from her very first week back from family leave. If anyone has gone through that, you can remember what that's like, your first day or days, not with your baby all the time. So can we give her a round of applause just for that? But I also just want to tell you a little bit about her in case you don't know her. Dr. Adekunle is a recipient of a prestigious Anna J. Cooper Fellowship here at UW, and then will be joining our faculty officially this summer. Her research integrates insights from communication studies, public health, and disability studies to design and execute community-driven projects aimed at identifying multi-level barriers to perinatal well-being, improving the quality of obstetric care, and enhancing birth outcomes. Her PhD is in health communication from Purdue and did a postdoctoral fellowship at Northwestern Feinberg School of Medicine. So please welcome Dr. Adekunle.
Yeah, thank you, everyone. I'm really excited to be back on campus and to share my research today. So this study looked at perceptions of pregnancy risk and self-protective health decision-making among U.S. Black women. I would like to acknowledge the Waterhouse Family Institute for their support of this work, as well as my co-authors whose names are listed at the bottom of the slide as well. Yeah, so as we all know, racial disparities persist in U.S. maternal mortality. We know that Black women are almost 4 times as likely as white women to die from a pregnancy-related cause. And what is striking about this is that it's not only a source of concern for clinicians and researchers and public health practitioners, but it also shapes public discourse around Black women's pregnancies. So when we think about Black women and their pregnancy journeys, we don't necessarily always come up with the most hopeful images or positive stories. This is not really what comes to mind. And so I've included this screenshot of a news article that discusses Black women's pregnancy-related deaths to sort of show how this has shaped the public imagination around Black women's pregnancies. And so for this particular study, I was very interested in how do, within the context of this discussion of how dangerous pregnancy can be for Black women, how are they conceptualizing of their pregnancy risks, and how is that shaping how they make decisions and enact agency in response to these risks? Because as we know, people don't just formulate their risks based on what a statistic says. They take in a lot of information and they act on that information. And that information informs their health decision making and then can inform their health outcomes as well down the line. So this study used a qualitative research design. We recruited participants online and in person. And so participants were eligible if they self-identified as women and Black, and we're currently recently or planning to become pregnant. All participants were over the age of 25 and under the age of 39. We recruited across about 11 US states and multiple different professions. One thing about the sample for this study was most participants were highly educated, and I think that also will shape some of the findings that we saw as well. To analyze our data, we transcribed audio recordings and then coded our transcripts. We first took notes to become familiar with what the data set included. We developed our initial codes, coded collaboratively to identify broad themes, and then refined and finalized those themes in an iterative process. So this is just a snapshot of what our findings were in terms of domains of risk perception. There was thinking about healthcare as both safe and dangerous, concern for life and well-being of oneself, as well as concern for life and well-being of one's fetus or child. In terms of self-protective responses, that included research and self-advocacy, intentional decision-making, and selective participation in healthcare encounters. I won't be able to go in detail on all of these for the sake of time, but I would just highlight some of the key things that came up. So in terms of domains of risk perception and this idea that healthcare was perceived as simultaneously safe and dangerous, our participants understood that by going into a hospital or engaging with a healthcare provider, clinician, they were getting care, and the healthcare provider would let them know if something serious was wrong. But at the same time, they had very profound concerns about things going wrong. And a lot of that was rooted in anticipated bias or previous experiences of bias that they thought they might face. So these 2 quotes are actually from the same participant who, on the one hand, said that she was pretty sure that her doctors would let her know if something was wrong, but on the other hand, also said that she believed that doctors don't like Black people. So there's this idea that the doctors would be helpful, but at the same time, they're biased against me, that sort of dichotomy. I also included these quotes to sort of illustrate other concerns that people had about the danger of healthcare.
So this person described staying home as long as possible during their labor, which is a really common strategy people use to be safe, because she didn't want to be pressured into doing things that weren't really on her birth plans. That's what that first quote says. The second quote also had to do with being allowed to make a choice and concern about having her sense of choice or agency or autonomy eroded. And these are two different quotes from two different participants. So I'm going to talk a little bit about the concern for one's life and their well-being. So that included physical health and what impact pregnancy might have on one's body and the threat to life, included mental health and impacts on career and education. I'll only talk about physical health again, just for the sake of time. This quote really captures the fear that a lot of people expressed about losing their lives during pregnancy. This person said she had heard stories about people dying during pregnancy, and being a Black woman, she was really afraid that she was going to experience the same thing based on the horror stories that she had heard. So now I'm going to kind of talk more about how people express concern about the well-being of their fetus or baby. People express concern about their baby developing in a healthy way, especially when they had people in their families that had developmental conditions that had impacted the well-being of a baby. They also expressed concern about the safety of their child after birth. So I'm going to read this quote. This person said, it's like the child has to grow up endangered, like in an endangered environment. People want peace for their child. So to put that in a little bit of context, she talked about the neighborhood that she lived in and the violence in the neighborhood. And so being really concerned about just the life that she was bringing her baby into. But then there are other people who talked about their baby being exposed to racism and what that might look like. For example, for a male child who would have to grow up as a male child in the United States, and all of the risks that are associated with that. So now I'll talk about how people were responding to these risks. They weren't passive. They were making decisions to protect themselves and optimize their chances of good outcomes. So one major way that people did this was through extensive research and self-advocacy. I was actually really surprised by how much people described just doing research and reading deeply into all the different forms of treatments that they were being offered, just to make sure that they were getting the best care that they were. And again, I think this kind of goes into a lot of the participants of this study were college educated, for example, and so they knew how to engage with information, and they made an effort to do that. So this participant shared, I read, scholarly articles on all the medications and best practices for different things as they came up. I did a lot of literature reviews on my own, just to read about side effects and what has been done, what is evidence-based and what is in the gray area, so I can get a better idea of the rationale for why. So this is a big part of how she participated in her care and partnered with healthcare providers. Another thing that came up was people really seeking racial and gender concordance with the healthcare providers. They thought that having a healthcare provider of the same race and gender would, again, just increase their chances of things going well. So this person shared that she wanted her healthcare provider to understand that pregnancy is a life or death thing, and that by having a Black female doctor, the doctor would get it, would understand, and would listen to her. Doulas and midwives were also, people highlighted that engaging doulas and midwives would help them also have more successful or more preferred experiences during their pregnancy care. They mentioned that doulas would ensure that they were safe, that they were cared for, that they were fine, and there was that trust that was expressed in doulas. People also leaned on peer support, especially when people within their networks had expertise in medicine of some sort. So this person talked about her line sisters and how they became her doctors, even though they weren't officially her doctors. She was sending them her blood pressure, sending them information about her health. And she says at the end there, I didn't really care what my team had to say at that point. So I feel like the friends and line sisters helped her get through the pregnancy. She wasn't really paying attention to what her actual doctors were saying at that point, because trust had been eroded in terms of what she had experienced so far. This was kind of interesting in that some participants described taking actions that could potentially have had a detrimental impact on the care that they received. For example, not communicating with the healthcare providers about what they were fully experiencing or not adhering to recommendations. For example, this participant had mentioned she didn't want any medication that was being offered to her because she anticipated that the doctor might give her something to harm her or might try to operate on her to get something out of her. I wanted to highlight this as something that came up as well in the data. People expressed inactive agency in response to pregnancy, to the risks that they anticipated in ways that I've already described. But sometimes as they try to assert themselves, gendered racism was constraining their response in that the providers that they were interacting with, some occasionally were not always supportive of their goals and would actually kind of erode their agency in those moments. So for example, this participant described noticing the drawback in how her doctor was relating to her when she tried to assert herself and not get an epidural. And she said it seemed like it was making his job harder. And that eventually, after she had tears, the doctor had sewn her up without any pain relief medication or anything like that. And what he said to her when she complained was that if she had just listened to him and taken the epidural, she wouldn't be experiencing that pain. And so the data and also the literature suggests that this is related to gendered racism. So just to conclude, some key takeaways from this work: Black women are highly cognizant of and responsive to the heightened dangers they face during pregnancy. These self-protective strategies highlight some opportunities to further empower Black women to be effective self-advocates, since this is something that they're doing anyway. And I want to highlight that these self-protective decisions to mitigate risk are made necessary by structural failures and gendered racism. So I try to avoid kind of like making it seem like people are heroes in their own healthcare. They shouldn't have to fight for their lives, right? And so it underscores the need for interventions to continue to reduce the objective vulnerability that people experience, the Black women experience in their pregnancy care.
Thank you for presenting this insightful work on people's experiences. So there is a lot of conversation around patients advocating for themselves, but in what you've just shown, there also needs to be a receptivity to that advocacy. So what would be your perspective on how we can encourage the receptiveness to a patient advocating for themselves?
Yeah, I feel like it's really important just across the board in medical education that the medical students are encouraged to really see healthcare as a partnership between themselves and their patients, and to really understand that when people are advocating for themselves, one, I think having the context of, okay, they're not just advocating for themselves out of the blue, they're aware that this poses a threat to their lives in ways that it might not for other people. And so that's where they're coming from. So I think acknowledging medical students within their training being exposed to studies like this that kind of show where patients are coming from in their healthcare, I think that can help physicians to understand that people aren't being difficult, right? They're not being just trying to be non-cooperative, but they have real reasons, real and valid reasons to advocate for themselves, and they should be supported in doing that. And so I think the real question is healthcare providers really thinking through, how can I partner with my patient? How can I recognize that this is a concern that my patient has? And how can I make them feel more comfortable and make them feel more safe? And I do have a publication that's kind of an offshoot of this one that goes more into patient-provider communication and how providers can alleviate some of those perceptions of risk. So there's a paper that has some more practical recommendations there too. Thank you.